Today we're going to think about pathology of the thyroid gland. You really do have to be a pathology superhero to recognize thyroid disease. It's really common, but the symptoms can be insidious. Important diseases when we're thinking about pathology of the thyroid are hyperthyroidism, hypothyroidism, goiter, which is swelling of the thyroid, and solitary nodules in the thyroid gland. People often ask, what's the best test to do to measure thyroid gland function? Because after all, we have to know whether someone's got hypo or hyperthyroidism. The best tests to do are free T4 and TSH. Don't do complete T4, because then you're just measuring the amount of protein in the blood that contains T4. Only the free T4 is active. The table at the right here gives a quick summary of how to interpret the free T4 and TSH in order to diagnose hypo and hyperthyroidism. You might want to stop the video and take a moment to look at it. Most hyperthyroidism is due to an intrinsic thyroid problem. We call it primary hyperthyroidism. And most of those are due to Graves' disease. Now, you might have heard of Graves' disease before because people often use it as an example when thinking about basic autoimmune pathology. In Graves' disease, autoantibodies are formed and they bind to the TSH receptors, turning them permanently on. So the light switch in the thyroid is permanently switched on, and this gives rise to the hyperthyroidism in Graves' disease. Some causes of hyperthyroidism are due to a functioning adenoma, a small benign tumour that overfunctions. And very occasionally, multinodular goiter can cause hyperthyroidism. More on that later. Secondary hyperthyroidism is due to production of too much TSH in the pituitary, perhaps due to a functioning pituitary adenoma. It's very rare. Hypothyroidism, underfunctioning of the thyroid gland, is most commonly caused by Hashimotos disease, another autoimmune disease with a completely different mechanism. In Hashimotos disease, CD4 positive T cells produce antibodies to a variety of thyroid antigens. These release cytokines that tell the thyroid cells to die. It's classic apoptosis. And they cause B cells to produce anti-thyroid antibodies, which block the TSH receptors. So, hyperthyroidism in Hashimoto's disease has two mechanisms, one driven by antibodies blocking the TSH receptors, and one driven by a direct attack of T cells on the cells that make up the thyroid follicles. In the picture at the right, you can see a thyroid gland. It's now full of lymphoid tissue. Those ball-like things, they're lymphoid follicles, and they're pumping out those B cells to produce the antibodies that will attack the TSH receptors. In between, there are lots of T cells delivering that cytotoxic death message to the follicular cells. Goiter is a benign increase in thyroid size. It's due to defects in hormone synthesis, very commonly due to insufficient iodine. In goiter, the thyroid enlarges and the TSH produced by the pituitary goes up. The reason for this is the feedback loop, which says, We need more free T4, and the TSH goes and tries to push it up. But of course it can't, because there's insufficient iodine. All goiters start off small and gradually increase in size, and as they increase in size, they become multinodular. Giving iodine to patients who have a multinodular goiter can cause acute hyperthyroidism. That's because the thyroid is in a situation of overstimulation by the TSH, and if you feed it iodine, then it'll just go into hyperdrive, and hyperthyroidism can occur. The table at the right here shows laboratory free T4 and TSH in people with multinodular goiter. Notice the TSH is always increased, but the patients can be euthyroid if they're compensating with a normal free T4, as well as hypothyroid, the most usual. But if they're given iodine, you will drive them into hyperthyroidism with a high T4. Solitary nodules in the thyroid are really common. 3% of adults will have one. Most of them are benign. And when I say most of them, 99% of them are benign. Either an adenoma, a benign tumour, or a prominent nodule in a multinodular goiter. Thyroid cancer is present in only about 1% of solitary nodules. But all solitary nodules need working up to exclude thyroid cancer. There is a diagnostic algorithm for thyroid nodules, which I suggest you don't memorise, but look up on your phone when you actually need to know it. It's based on 3 questions. Is the TSH high or low? Is the ultrasound scan suspicious? And does the radionucleotide scan mean the nodule is hot or cold? Most of the pathways lead to a fine needle aspiration of the thyroid. The report you get back from the fine needle aspiration will be classified into 6 categories, which tell you what to do. Let's first think about hot and cold thyroid nodules. A hot nodule signifies increased thyroid hormone production with increased iodine 131 uptake. The picture on the right shows a single hot nodule in the right lobe of the thyroid. This is a hot nodule where there's increased production of thyroid hormones. If the thyroid is normal and the person is euthyroid, we get the picture in the middle, where the thyroid evenly takes up the radionucleotide. If we have a cold nodule, there is a decreased production of thyroid hormones in this area. You can see in the picture on the left lobe of the thyroid has an area of non-uptake, because it's a cold nodule. Hot nodules are much more likely to be benign because papillary carcinoma of the thyroid does not produce hormones. This is the Bethesda classification for FNA of the thyroid. It's a great classification because in the column under management it tells you exactly what you have to do with the result. If you do an FNA of the thyroid or request one, you will get a report back like this, including the diagnostic category, the risk of malignancy, and what management should happen next. The pathologist will do most of the work for you in deciding the next steps for the patient. Let's think about papillary carcinoma of the thyroid. 80% of thyroid cancers are papillary carcinoma, and most of the rest are follicular carcinoma. The key words in describing papillary carcinoma are a papillary growth pattern. So this is when we get papillae which have a fibrovascular core covered by epithelial cells. Now the cells that make up papillary carcinoma are really distinctive. They have nuclear grooves. That means they have folds down the middle of the cells. If you look at the picture on the right here, you'll be able to see some cells that have folds down the middle of them. They look like coffee beans. The other thing that's really common is nuclear clearing. So down at the bottom right-hand picture, you've got a nucleus that has a white area in it, and that's nuclear clearing. In the middle of the picture, just on the edge of the curve, you can see a nucleus with a kind of pink round thing in it, and that's a nuclear inclusion. Because the nuclear features of papillary carcinoma are so distinctive, it's really easy to diagnose on FNA. Papillary carcinomas are one of those cancers that have a really great survival rate because we can treat it with surgery and with radioactive iodine. 98% of people with papillary carcinoma will be alive at 10 years, most of them cured. So today we've thought about how to test for hyperthyroidism and hypothyroidism using the free T4 and TSH. We've then thought about the diseases that cause hyperthyroidism and hypothyroidism. Hyperthyroidism, mostly caused by Graves' disease. Hypothyroidism, mostly caused by Hashimotos disease. We've then considered goiter, particularly multinodular goiter, and then solitary nodules. When thinking about solitary nodules, we thought about how to classify them and how FNA can lead to important management decisions. Finally, we thought briefly about papillary carcinoma of the thyroid. Thyroid problems are common in our society, and diagnosing them accurately will make you a pathology superhero.